note, I would now invite none other than Dr. VAISHALI, who needs no introduction and has been a key instrumental toric IOL implanter all over the country for the last many years. Let's hear from her about multifocal toric and challenging case scenarios. Over to you, Dr. VAISHALI.
Thank you, Dr. Swati, a very dear friend, and I'm so happy to be here. And I'm really happy that on this last day, last session, we have a full hall. So hats off to you, Dr. Swati.
Hats off to the audience, actually.
Really.
And they're so interactive.
Correct. So I'm enjoying this course, and I must say that we do have occasional research support grant from Alcon Laboratories, and all of us have a financial interest in torics and in multifocals, irrespective of the brand. So my talk being more on multifocal and special scenarios, I think we need to understand, as has been discussed all through the course, that any residual refraction, particularly in a multifocal or a trifocal or an EDOF, whatever, is going to adversely impact your outcomes, and it is typically the most common reason for a dissatisfied patient. So I think it's learning or having a mastery of toric IOL or any kind of astigmatic correction is a basic stepping stone before you even start a multifocal practice, because in today's date and time, with as small as 0.5, 0.6 being correctable, we have to do that if we are also planning to give the patient a spectacle freedom. So I think that is very important when we start the background. And for us, when we do a pre-op assessment, the most important thing we look at, first thing, is the amount and the type of astigmatism. We'll decide which way we are going to counsel the patient, and which was very nicely mentioned by Dr. Bhargav also, that it should be and in the first talk also, that it should be the first evaluation, and the patient should, as soon as the optometrist or your technician sees an astigmatism, they can even just start putting a word about this availability of a toric lens. It may or may not be suitable for you, but there is this thing which is already available. So like I said, if the patient has a negligible astigmatism, we will go towards a monofocal or multifocal. When I say, I mean a trifocal or an extended range of vision in today's technology. If there is significant astigmatism, it is either a toric monofocal or a toric with extended range or a trifocal. So that sort of classifies our thing. Where is the cutoff? As we have discussed amply, I won't go into this, but anything 0.5 or more, we have to give the option. And like Dr. Paul said, maybe you will do a femto AK if you have access. If the patient is already paying more than double for his surgery, his or her surgery in your femto, you might as well add in this, but you have to address the astigmatism. And the preoperative evaluation, which I don't want to go into details, was very beautifully covered, has to be to the mark. If you don't have access to a topography, probably when you are planning multifocal torics, this is the time when either you do it at your place or refer it to a colleague who has a topography. In a monofocal toric, you might still get away sometimes. And I think the good news now is that there is too much of counseling and talking about the negative side effects or personality assessment. With the new trifocal torics and across platforms, I don't mean any one brand, all the three brands that are available, and in fact this meeting I even heard one or two Indian companies have launched their trifocal torics as well as EDOF torics. So now we have these available. Trifocal toric is my #1 choice for anybody who says that I don't want to wear glasses. I don't think too much if the eye is a suitable candidate. If somebody is very particular in terms of their personality, or if their eye has something which is not exactly within ±2 standard deviation, then I would go for an extended range of vision IOL and astigmatism correction. So I think there are negligible side effects, and I'm sure everybody on the panel will agree that the glare, the halos, the waxy vision, they have not gone away, but they are not so much of a bother for us so that we hesitate in suggesting these lenses to patients. Let's go to some case scenarios. Here is a young person, 33-year-old, and unfortunately post-COVID we have been seeing so many people below 40 and we have been operating them. So now it is even more important. And like we discussed, yes, when maybe 20 years down the line this guy will have and shift towards against the rule astigmatism. Right now you have to treat for now and the youth, prime of the youth that they are going to be in. So one diopter cylinder in the refractive correction. And the other eye has already had a surgery elsewhere with a full optic diffractive multifocal IOL. And this is after that multifocal. So left with a residual astigmatism and therefore very, very unhappy. And now says that I don't want a multifocal because not only I've not gotten rid of my glasses, I also have these other problems of the multifocal. So what would you do now? Safest is to put in a monofocal and say, or a monofocal toric and say that, yeah, okay, get on with glasses. But then that's the whole thing, that if you have access to technology and if you understand the eye well, you can even do a second eye of a little bit unhappy patient. So what we saw, this is the operated eye. And this is an abrometry, just to orient those of you who don't know, this is an eye trace, ray tracing abrometry. Pointer hai. I'm not getting my cursor on this. So if you see the bottom left, that is the astigmatism coming from the cornea, and the top right is that coming from the total eye. So which means that the cornea is contributing to his entire astigmatism, which is about, even in the eye trace, which is a beautiful autoref, it shows 2 diopters of cylinder. And which is why the visual quality is like this, because the cornea is giving rise to a blur. So the good news is that you can correct it in the other eye. Now the other eye, which is the left eye, has 1.5 diopters of with the rule astigmatism, and otherwise ocular profile is suitable. So we did cataract surgery with a toric IOL here in a monofocal, because like I said, the patient just didn't agree to get a multifocal, even despite 2 or 3 counseling sessions. The other thing I also want to highlight is that in any case of a multifocal or toric or such an odd challenging situation, it is very important to have more than one session of counseling. It is very rare that patient is so crystal clear in their mind that this is what I want or don't want. And sometimes the right relatives, like Dr. Ajay Paul pointed out, are not there with them. Or you may have to talk to them on the phone. Okay, please talk to my son who is in US or this, that. So have more than one session and tell them that these are the options, and then most likely they will go for the one that you suggest. And this is the post-operative picture in that other eye where we did a monofocal toric IOL. Again, like I said, just because the patient was so scared of having a multifocal. So many times the multifocal lenses get a disrepute just because they were left with a residual cylinder. So that is another point, that we need to explain to this patient that it's not the multifocal, it's just that you have some astigmatism. Now we go to this another scenario where this is a middle-aged gentleman, and I say middle-aged because as I grow older, my bracket for middle age also keeps moving up. So bilateral cataracts, a very active lifestyle, and plays golf. Now his main thing is that now that I'm going to retire from my active profession, I want to be able to play golf all day long, 5-6 hours a day, and I don't want to wear glasses. Now golf, as we all understand, is a very sunlight intensive game also, a lot of outdoor exposure, a lot of dryness, everything is going to come in. And this person has a regular corneal astigmatism. So we did trifocal toric IOLs in both eyes after a very good counseling session, or let's say more than one. And he's very happy now because his whole thing was, I want to play golf without glasses because my colleagues feel that my glasses keep slipping off and all that. So I think again the point here is that with the newer IOLs, these dysphotopic phenomena are, I would not say not there, but very, very less, and therefore you can do toric IOL or trifocal or any form of multifocal toric IOL correction, even in people who have so-called red flags. In about 10 years back, we used to say with the +3 and +2 type of IOLs, we would say that please don't do that because they would have a lot of glare. Now moving on, toric technology in general, how we keep expanding our horizons as we ourselves learn from our good and bad experiences. Now this is a 42-year-old lady, known high myope, and radial keratotomy is done several years back, and you can see that she has a typical nuclear cataract with some degree of posterior subcapsular cataract also. What is important to note here is that look at her case, 31 and 33 almost, and obviously a high axial length, and she has about 2 diopters of astigmatism, which you will see here. Now, to our surprise, and thanks to the RK surgeon who spared the central cornea, the central cornea, if you see on the topography, has a very regular astigmatism. Now what we need to see, most devices, all topographers, pentacams, abrometers, they will give you the patient's pupil size during the scan capture, which is this black circle. So, and also what we do as a practice, at least for those of you who don't have the highest end SSOCT, the swept source OCT, the newer machines say that they are going to be independent of the illumination. But until now, whenever we capture a scan, it has to be done in a mesopic light. That means you don't necessarily have to put a black curtain or cloth over the patient, but switch off all the room lights so that in a physiologic mesopic condition, what is the pupil like? And we being pigmented races are usually blessed with not so dilating pupils. And like you can see here, it gave up IOL power of 30 diopters, T4 model of that particular brand, because the mesopic pupil has a regular corneal astigmatism. We also did an abrometry, and we found that again the same thing. This has also a placido disc topography, and again coming to the point that in these eyes, these are the eyes when you want more than one type of technology. In a regular patient, it's okay if you just have one or max two. But here we confirmed it with the eye trace or the abrometry. And we found that the total higher order aberrations were not that high. And we went to the ASCRS post-refractive calculator, which still is our go-to and again freely available. And this is what the patient looks like post-operatively. You can see beautifully the toric marks there. And so again, you can see here that the central cornea looks pretty clean. And therefore, 1 month follow-up, she's 6 parts plano. You don't expect a 6x6 in every eye. This eye probably never had a 6x6 because she's been a high myope. So the point is good functional vision. Even if it's 6/9 or 6/9 partial, for that patient, that's the best vision they have ever had. So that is something we need to keep in mind. And post-operatively, this is corneal astigmatism being cancelled by the intraocular. Now, this is one last case I wanted to show. This is a 53-year-old share broker and has always been myopic, moderately myopic with some astigmatism, and he wants to continue his distance glasses and not wear reading glasses because that's how he's been used to. And we did a toric IOL calculation with a target myopic refraction. So the point is that there will be those occasional patients who are not ready to give up their unaided near vision and who don't want to, or who may not be suitable candidates for a multifocal technology. So in these cases, you can definitely consider toric IOL even with a myopic target. The whole idea is to give them good quality. So even for near, if you knock out the cylinder, their reading vision quality is going to be much better. So that's one message I wanted to show. And the last case of a pterygium, which is also a very common scenario. In a significant pterygium which is causing distortion in your readings, do a pterygium, wait for at least 4 to 6 weeks. So this was the pre-op, very irregular astigmatism. This is what it became post-op and the mesopic pupil. So you could very well go ahead in such eyes and do a toric. I think the most underrated thing is your staff and your team, because unless everybody talks about toric, unless everybody shows that confidence on their faces, on their language, it's not going to work. It's not going to go to the level that we want it to be. Thank you so much.
Very nicely explained all the facets of multifocal toric and the scenarios. So do we have any questions from the audience here? So Dr. Vaishali, what happens if during the operation you face a PCR or a rhexis run out? What do you do in those scenarios? Would you go ahead with a multifocal toric, or would you change over to a toric or a plain monofocal?
So that's a very tricky question, and I don't think it has a clear-cut answer, but if we look at a rhexis run out, if at the end you end up with only that localized run out, it has not extended behind, depending on again the kind of material that you are using. Most hydrophobic lenses across platforms have a very sticky nature, so you could go ahead and do that. But again, I would be very cautious because the other thing is going to be that tilt. So if you are very, very confident in your surgical outcome, then that is one thing I would do for a monofocal or even a multifocal, and I have done because I tend to have all kinds of complications. In a PCR, general answer is no, because it's not only that multifocal toric, there are so many other issues that are going to come up in the future. So As a general answer, no, but sometimes we have done small central PCRs, converted to a rexis, and then just put it in.
So I think it depends upon the surgeon and their expertise and how you want to go ahead with it, the patient expectations, the patient who's lying on the table. So there are multiple facets to this. Dr. Ajay Paul, sir, what is your take on this question?
I have had quite a few, if not all, the plain multifocals, the torics, with a little bit of rexistran, is not gone in, pressed it. I'm talking about all the hydrophobic trifocals rather. Very recently, I had even had a trifocal where in a femto the rexis had bit runoff, and I'm following those patients for almost 9 months. So normally it doesn't, but yes, torics probably a tilt would come in if it is more, because there would be a tilt even with the trifocal, but somehow, with the patient, if the pupil is the sopic pupil is small, it doesn't give that much of a problem. With the toric, maybe you would again get up with some cylinder toricity, but then yes, I would not hesitate to put the lens.
So would you like patching the patient and giving?
Yeah, normally again this any I just forgot to say, for high myopes, for where I haven't had a difficult situation or I put in a toric, it's always I keep the patient 4 to 6 hours patched in my hospital, send the patient patched, and maybe for 24 hours patching. All high myopes in torics, I do that, for at least 2-3. See, the idea of patching is, especially these high myopes or myopes, the lens is there in your bag as the year forms up. So the idea of patching, keep the eye in rest. Any stress, patient gets up and walking, there would be a little bit of forward and backward movement. So that could rotate. I mean, there have been instances where we have put in a eye myopic, anything below 18 diopter or 19 diopter where I'm putting in toric, I normally
rotation we've seen in the first 24 hours. So it's usually ideal to limit the movement of the patients in the initial 24 hours. Tell the patient to take rest in a dark environment, not talk much, not move his eyes. So we usually say we've done this premium IOL, go home. So this is how it is marketed usually. But for toric IOLs, just be wary of this. And it's like a little under counseling, stay at rest for the first 24 hours.
So I think that this is a great point, and there is a very beautiful study from, I think, Japan or Hong Kong, which showed that the maximum
I'll
rotation.
present this.
Sorry, then I don't need to say anything.
Actually, there is a constant leak from the anterior chamber to outside. It's fast 24 hours. In every cases, either you hydrate wound or because there is too much of pressure inside the eye, it will leak somewhere. So it is always from inside to outside, never outside to that's why there is an incidence of endophthalmitis is less. So there is a fluctuation of IOP in maximum in the first 1 hour and after that. So it is, if some surgeon prefer to patch the eye 1 hour in cases toric, it is a